So yesterday we were discussing about the medication, preoperative medication. So we had come up to the steroids, and very important is the steroid intake and then the anesthesia implications of steroid intake. So
Yes, sir.
because these patients can be on inhalational steroids, these patients can also be on oral steroids, especially if the allergic problem is more, like if they have got an ACOS, so asthma and COPD or syndrome. So they'll be on increased doses of steroids. And now the thing is, now if the patient is on steroids, so what are the anesthetic implications of steroid intake?
So patients on long-term steroid therapy, they'll be having that adrenocortical suppression, sir. So because of its as anesthetic implication, you'll have there will be central obesity, Cushing syndrome features, central obesity, buffalo hump, moon faces, and all, which has to difficulty in airway and diaphragmatic ventilation also. And then it is for long-time steroid usage, there also will be more chances of hypertension, hyperglycemia. Patient will also prone for delayed wound healing. He will be immunosuppressed.
Hypokalemia. So most important because, of course, that is one thing, because whenever I have moon-shaped face and then buffalo hump, because of Cushingite features, so that produces a very difficult airway for us. And they also will have severe osteoporosis, so positioning will be very difficult because they may develop fracture. So hyperglycemia, hypertension will be associated with hypokalemia. That is another in these patients. So that
also oral candidiasis.
Yeah, that you have to keep in mind. Plus, most important, other important thing is the hypothalamo-adrenal, or pituitary adrenal, in the, that axis is suppressed.
Yes,
Inhibition of HPA axis. So when do you think that these patients have an HPA axis suppression and have adrenal insufficiency?
Sir, we have a rule of 10, sir. So if the patient takes more than 10 mg prednisolone for more than 10 days, within 10 months, then we have to think that patient will probably have hypothalamo-pituitary adrenal suppression, sir.
So, but how do you prove that, whether the patient has adrenal insufficiency or not? Do we have any test to prove? Because sometimes, this is only assumption. Rule of 10, of course, that is very good. If the patient has taken more than 10 milligrams per day of prednisolone for at least 10 days continuously, within 10 months, that is what you said. So can we have some cortisol estimation and then find out whether adrenal insufficiency is there or not, or adrenocortical suppression is there or not?
Serum cortisol.
Yes, sir. Serum cortisol sent in the evening.
Cortisol levels will be normal only many times, even though they have an adrenal insufficiency. Because adrenal insufficiency occurs when they are stressed. And we know that they can be stressed under anesthesia and surgery. That is the time they may not respond by releasing a sufficient amount of steroids, isn't it? So how do we know whether they have these kind of, they may not respond to the stress situation? Now you'll have to give 250 micrograms of, first you get the blood and estimate the cortisol level. Then 250 micrograms of ACTH is, injected intravenously, and wait for 30 minutes and then draw the blood and then again estimate the cortisol level. The increase in cortisol level should be more than 25 micrograms per ml. Increase. Not talking about the levels. Levels, whatever it may be, the basal levels, compared to the basal levels, it should be increased by more than 25 micrograms. If the increase is less than 15 micrograms, then you can know that exactly that these patients have adrenal insufficiency and they do require, supplementation preoperatively. And one more thing, I just want to ask you, another exam question. What is the amount of cortisol that is released every day, per day, normally? Per day release.
20 micro.
No, don't guess. If you know, you can tell. If you do not know, I'll tell.
No.
So it is usually about 9.9 milligrams per day release of total cortisol release roughly you can say 10 milligrams. So this also can be another thing about rule of 10, what you were talking about. So 10 milligrams will be released. So whenever these patients are exposed to severe stress, like major surgeries, then, the amount of cortisol that is released in the body in normal persons with normal hypothalamo-pituitary adrenal axis is more than 100 milligrams. Within 24 hours, more than 100 milligrams of cortisol will be released to combat the extra amount of stress that is there whenever they are exposed to major surgery. So in these patients with HPA axis being suppressed, they'll have adrenal insufficiency. They cannot release that amount. So they do develop problems. What problems you can expect them to develop if they have adrenal insufficiency when they're taken up for intermediate or major surgeries?
Sir, patients will have a severe hypertension, sir.
Circulatory collapse. So one word you can always say, they can go for circulatory collapse. So that is a problem. So that is the reason many times you may have to supplement. So another thing you are talking about rule of 10. One more problem in these patients, many of these patients can be on inhalational steroids.
Yes, sir.
So when they are on inhalational steroids on long term, should we have to supplement them or not?
No, sir. For oral steroids only we have to.
No. It all depends on what is the dose of inhalational steroids they'll be on. And budesonide is one of the most commonly used in India, the inhalational steroid.
Yes.
So you have to see what is per day dose of budesonide they are taking. When they are taking more than 720 micrograms of budesonide per day, inhalation route, more than 720 micrograms. Because, it is always less than 360 is, very mild amount of inhalation of steroids. 360 to 720 is moderate, and anything above 720 is high dose of inhalational steroids. So if they're taking anything more than 720, that is the important thing about, in your pre-anesthetic evaluation, you have to really check how much of, suppose if the patient is telling you that he is on inhalation steroids, you'll have to really know how much per day. So if they are taking more than 720 micrograms for a long term, so they do have HPA axis suppression, so they do require supplemental steroids. And again, another question you will be asked definitely, and it is very important because you have to give the supplemental steroid, and based on the amount of the steroid that should have been released in the body. That's what I told you. Major surgeries release is more than 100 milligrams per day. And it continues for 5 to 7 days. This release of cortisol continues for 5 to 7 days in patients when they are exposed to major surgery, severe stressful situation. So you have to, mimic that whatever the body would have done, isn't it? So that is why you classify these surgeries as minor surgeries, intermediate surgeries, and major surgeries. Okay, now you must be knowing about at least this thing. You can tell minor surgery, how much, intermediate surgery, how much supplementation is required, major surgery, how much supplementation is required.
Minor surgery.
One hour before.
Yes, sir.
Even hydrocortisone, though it's a short-acting drug, the onset of action gets delayed. The peak action may take about 1 hour.
Yes.
That is why all these steroids, if we want to give as a supplemental dose for prevention of adrenal insufficiency, you have to give 1 hour before, preoperative dose. Okay, and intraoperatively and postoperatively, do you require?
For minor surgeries, we do not require.
Minor surgery, you don't require. Intermediate risk surgeries?
Intermediate risk surgeries, same 25 milligram, we have to give 1 hour prior to surgery, sir. And then 100 per day for 1 day alone is enough.
Yeah, 100 milligram per day means how do you give?
Tedious.
No, because duration of action is hydrocortisone.
6th hourly.
6th hourly, you have to give how much?
25
That is what you have to tell and also write down in the exams. 25 milligrams every 6th hourly for just 1 day.
1 day.
So from the time you have given or from the time the surgery starts, so over 24 hours, you have to supplement them with 25 milligrams every 6th hourly for intermediate surgery. For major surgery,
for major surgery, 25 milligram 1 hour prior, sir, followed by 100 mg per day for 3 days, 3 to 5 days, sir.
Yeah, again, this 25 milligrams 6th hourly.
6th hourly, sir.
For 3 to 5 days, you have to continue. So that is for major surgeries, mimicking how the body would have released cortisol. And one other question will be for you is patients need not be on prednisolone all the time. They can be on other steroids as well. So they may ask you about equipotent doses of other steroids. That also you'll be knowing, and just for the sake of others, you can just tell about that.
So for prednisolone, 10 milligrams of prednisolone is equivalent to 40 milligrams of hydrocortisone, which is equivalent to 8 milligrams of methylprednisolone, and which is equivalent to 1.5 milligrams of dexamethasone.
And betamethasone?
1.2.
1.2 of betamethasone, 1.5 of dexamethasone. And hydrocortisone 40 milligrams.
40 milligrams.
Prednisolone 8 milligrams. So, and triamcinolone?
8 mg.
Now again 1.5.
0.5.
They are all equipotent. Triamcinolone, betamethasone, dexamethasone, all those things. So this again, another important thing about equipotent doses you should always be knowing. So those things are about the patients having pre-medication, the preoperative medication and their anesthetic importance. So now we will go in for the examination part. Because you had total, you have presented and also summarized this patient having COPD and posted for, lap cholecystectomy. For what he is posted? He's posted for lap cholecystectomy.
Lap cholecystectomy.
Yeah, okay. Now, after this, we will go for general examination and systemic examination. We'll see what all the things we'll have to discuss regarding these examination findings. Just read out.
So general examination, the patient was asked to sit comfortably in the pre-anesthetic assessment clinic. Patient was alert, oriented to time, place, and person. He was moderately built and afebrile. His stats were like height of 170 centimeters, weighing 60 kgs with a BMI of 20.7. On general examination, no pala, icterus, cyanosis, clubbing, and generalized lymphadenopathy or pedal edema. Jugular venous pulsations examined in semi-recumbent position at 45 degrees. It was not elevated. So vitals, a pulse rate of 90 beats per minute, regular in rhythm, no specific character. All peripheral pulsations were filled. Blood pressure 130 by 70 millimeters of mercury, measured on the left upper arm in sitting position. Saturation, the patient maintained 96% in room air. Respiratory rate of 18 per minute, regular, and abdominothoracic hypertrophy. Airway examination, normal facial symmetry, mouth opening, more than 3 finger breath. Malambati class 2, and neck movements neck flexion and extensions were normal. Mental distance of more than 6.5 centimeters. Upper lip bite test class 1, and trachea was in median. Systemic examination, respiratory system, inspection, nostrils, palate normal, oral hygiene was good. Trachea appears to be in midline, chest appears to be barrel shaped. Both sides moves equally with respiration. No use of any accessory muscles for respiration, no rib crowding, no visible scars, sinuses, swelling, or pulsations were seen. On palpation, all the inspectory findings were confirmed by palpation. Trachea is in midline, chest wall moves bilaterally and equally with respiration. Shape of the chest, barrel shape, transverse diameter. Actually, it's a difference. Transverse diameter more 29 centimeters is more than anterior posterior diameter of 24 centimeters. Chest wall expansion of around 5 centimeters and vocal fermenters was normal. Percussion, resonant note felt over the left sternal border, and hyperresonant note felt over all other areas. On auscultation, normal vesicular breath sounds heard, expiratory wheeze heard, bilateral frying crackles heard in basal zones, and vocal resonance was normal. And bedside pulmonary function test was performed. It shows a breath holding time of 20 seconds and a single breath count of 13, and dyspnea index was grade 1. And Snyder's match blowing test, the patient was able to blow the candle kept at only 3 inches of distance. And Green and Burrows cough test, the patient was able to produce a strong and effective cough to bring out the sputum. And the forced expiratory time was more than 6 seconds. Cardiovascular system inspection, apical impulse was not seen, no visible pulsations. On palpation, apical impulse felt in the left fifth intercostal space, half an inch medial to the midclavicle line in left lateral position. No palpable pulse in pulmonary area, no palpable thrill or pulsations in other areas. Percussion, cardiac dullness not present in the left sternal border. On auscultation, S1 and S2 heard in all areas, no murmurs. Abdominal examination, inspection not distended. All quadrants of the abdomen move equally with respiration. On palpation, abdomen was soft, no warmth was present. Tenderness was present in the right.
No abnormality, isn't it? You can
Tenderness present in the right hypochondrial plate.
Yeah. Continue.
Yes, sir.
No, if there are no abnormalities,
CNS examination.
you just read the positive finding.
Okay, sir. CNS examination, all high mental functions are normal. So, provisional diagnosis, a 45-year-old male, resident of Kadalur and a driver by occupation who's a chronic smoker, came with complaints of upper abdominal pain for the past 5 years, associated with nausea, 5 days, associated with nausea and vomiting, with a history of breathlessness for the past 5 years, at present with MMRC of grade 3, with cough and expectoration for 8 years on regular treatment with inhalant agents for 2 years. He's a known case of systemic hypertension on regular treatment since 2 years. So probably a case of COPD without exacerbation at present, systemic hypertension and acute cholelithiasis, planned for laparoscopic cholecystectomy.
No, actually, you need not, when you are talking about provisional diagnosis, you need not have to write so much. You are not summarizing again. When you are talking about the provisional diagnosis, means it should be diagnosis. Like first thing you write down what is the patient posted for. Here you are telling that your patient is posted for laparoscopic cholecystectomy, 45-year-old patient posted for laparoscopic cholecystectomy with comorbid conditions of severity of the comorbid condition. You have to tell whether the COPD is mild, moderate, or severe. And also whether the other thing about hypertension, whether it is controlled hypertension or not. That's all should be as far as the diagnosis is concerned. You need not have to summarize the whole thing. You just say patient posted for laparoscopic cholecystectomy with moderate COPD, not having any carpulmonale, along with controlled systemic hypertension.
Yes, sir.
That's all should be your final diagnosis or provisional diagnosis. Okay. So you can, close this and we will discuss briefly about individual things because I have your, okay, general physical examination. General physical examination, the most important thing you have done properly, but the thing is again, you'll have to look for clubbing. That is, one is pallor you will have to look for. So majority of these patients, if they have associated desaturation, what will happen to their hemoglobin concentration?
It increases.
It should be high, isn't it? So they have cyanosis or desaturation. Also, they have a pallor. Then you have to be very careful because these patients will have significant nutritional deficiencies. So otherwise, you would be anticipating that they'll have a higher amount of hemoglobin. Absolutely, there should not be any pallor. That is one thing. Second thing is about the clubbing. That is another thing which you should always look for. Because yesterday we were trying to differentiate between bronchiectasis and chronic bronchitis.
COPD.
Yeah, in which condition clubbing will be there?
Clubbing will be present in bronchiectasis, sir.
Yeah, it's mainly present in bronchiectasis, any suppurative lung disorders. So like bronchiectasis or even the lung abscess and even CA lung also. Yeah. So other things already we have discussed when we discussed cardiovascular system like CVS, causes and the GI tract causes and all. We will not discuss. And you should know about many times when you mention about clubbing, you may be asked about grading of clubbing. I think you know the grading of clubbing. isn't it? So that also you'll have
Ah,
to,
yes, sir.
Yes.
if clubbing is there, what is the grade of clubbing? You'll have to mention there. So that is another very important thing. Again, cyanosis you should always look for whether cyanosis is there or not. So what saturation cyanosis will be present? What
Less than
hemoglobin?
90%.
Pardon?
Less than 90%.
No, 90% cyanosis will not be
Patients
present.
will
90% patients will be pink only. At what saturation? This is another very important thing, because when you say patient has cyanosis, and when you talk about the saturation, if you say 85%, 86%, 85% also will not produce cyanosis. It has to be less than 80% saturation. That means, so much of desaturated hemoglobin. And that too, what should be the amount of desaturated hemoglobin to be present to produce cyanosis? How much? Now it should be more than 5 grams of desaturated hemoglobin has to be present to produce. So unless that amount of desaturated hemoglobin is not there, patient will not present with cyanosis, even though the desaturation of oxygen saturation is less than 80%. So 5 grams of desaturated hemoglobin is very, very important. So in severe anemias, though they may have severe hypoxemia, they may not present with cyanosis. So that is again another exam question you will be asked. So you should know about that. And that is how the pulse oximetry is also very important. So if you have a finger probe pulse oximeter, you should always carry it and you should measure it. You have not measured that, I think. You have measured SpO2, you have written as 96%.
96.
So when SpO2 is 96%, you cannot say patient has cyanosis. It has to be less than 80%. That you should always remember. It should be more of venous hemoglobin. Because what is the venous saturation of hemoglobin?
75%.
75%. That is, what will be the PVO2? Venous partial pressure. 40 millimeters. So that is what, unless the PaO2 drops to less than 50 millimeters of mercury, or saturation comes down to less than 80%, patients will not present with cyanosis. So that is why cyanosis is a serious thing. Very severe hypoxemia if the patient has cyanosis. And what are the causes of cyanosis in a patient with COPD?
Sir, increased shunting, sir, and
Increased shunting. Why shunting? You think shunting can occur? It is not a hypoxemic problem, isn't it? It's a ventilatory problem. So hypercarbia, already yesterday we discussed about
yes, sir.
Alveolar air equation. If
Yes,
severe,
sir.
these patients will have almost normally also they may have 60-70 millimeters of mercury of PaCO2.
Yes.
And whenever they have such a high PaCO2, definitely alveolar air equation, based on that, the alveolar partial pressure of oxygen will be much lower. It may be about 70 millimeters or so, alveolar partial pressure. So again, the AA gradient, AA partial pressure gradient between alveolar to arterial partial pressure gradient can be between 5 to 20 millimeters normally also, based on the age. 0.3 multiplied by age in years, you get the AA gradient. The AA partial pressure gradient, alveolar to arterial. Suppose the patient is 80-year-old, COPD patient. His normal alveolar to arterial partial pressure gradient will be roughly 24 millimeters of mercury. That is 0.3 into roughly age in years. So suppose if his alveolar partial pressure itself is 70 millimeters, what will be his arterial partial pressure? Minus another 24. So it will be less than millimeters. So he'll have severe desaturation. And that is one of the causes for desaturation in COPD patients, because they have high ventilatory failure, not hypoxemic failure.
Yes, sir.
And second thing is,
Yes, sir.
they may develop carpulmonale. And any patient with carpulmonale will be in right heart failure. So what kind of hypoxemia these patients can develop? Carpulmonale patients. Yesterday we discussed 5 different types of hypoxemia. Stagnant hypoxemia, isn't it? So These are the two causes for
Stagnant.
cyanosis, stagnant hypoxemia. So they can have either because of increased carbon dioxide levels, or they can have because of the carpulmonale, they can have cyanosis. So whenever they have this cyanosis, you'll have to think what can be the cause, and they may ask you also in the exam. So another very important thing I just noticed when you presented your examination findings, especially regarding, you have written that barrel-shaped chest. No, for that you should know what is the ratio between the transverse diameter and anteroposterior diameter normally. How much, what is the ratio between transverse and anteroposterior diameter? And when do you say based on this ratio, patient has barrel-shaped chest? Hello, you are lost, or you're there? Ramanathan?
I think there was some network issue, so they're not in the meeting. I'll just look into that, sir.
They have ended the meeting, is it?
No, meeting's still going on, but they are not. They're not in the meeting, so I'll just.
Okay. Anyway, I'll continue. Let them join.
Okay, sir.
No problem, because these anteroposterior diameter and transverse diameter are important. You should measure when you are examining these patients. The transverse diameter is always higher than the anteroposterior diameter. The ratio between transverse and anteroposterior diameter can be between 1.2 to 1.5. It is a normal one. And you have to show when you are measuring and then telling that it's a barrel-shaped chest, the ratio between AP and transverse diameter should be less than 1.2, or usually it will be around 1. That means almost equal transverse diameter and anteroposterior diameter. Because here our students have measured and they have written it as 29 and 24 centimeters. So if I get the ratio, it will be more than 1.2. That is a normal one only. So you cannot just tell measuring 29 and 24 and telling that it is a barrel-shaped chest. Don't assume things. It is not a barrel-shaped chest when AP diameter and transverse diameter, they have a good normal ratio of 1.2 to 1.5. So that is one thing I want to mention. Second thing they have mentioned as the 5 centimeter as the lung expansion. Again, 5 centimeter lung expansion is not, and you don't expect 5 centimeter. Hello. Yeah. Come back. Okay. So I was telling about your few of the things you have said. AP and lateral transverse diameter. So again, last. Okay. So you can even close your video if your internet is not very good. So you can have the audio. So
No, sir. Just temporarily some internet issue.
Okay, so you should be careful, Ramanathan, and because your ratio between transverse diameter and anteroposterior diameter is more than 1.2, that is normal. 1.2 to 1.5 normal ratio. So you cannot have a barrel-shaped chest with that ratio. So it should be, the ratio has to be less than 1.2 or almost same as AP and transverse diameter is equal. 1.
Yes, sir.
Then only you can say it's a barrel-shaped chest. So be careful when you are presenting in the exam about this.
Yes.
So the second important thing is regarding the chest expansion. Now, how will be the lungs in these patients? What will be the position of these lungs in these patients? It is in a hyperinflated position. Hyperinflated position. That is what? Because of either dynamic hyperinflation or static hyperinflation, there is going to be a hyperinflated. It cannot expand much. You understand?
Yes, sir.
Or not?
Yes, sir.
Isn't it? So
Yes, sir.
normal chest expansion during maximum inspiration after maximum expiration is 5 centimeters. And your patient has 5 centimeter of expansion. That is a normal one. Then you cannot come to say that patient has COPD. See how this thing we can catch you in the exam. So you should be careful. Now what I am telling you is, so if you had written 2 centimeter lung expansion, then I would have agreed. then I would have agreed, because hyperinflated lungs, so naturally the expansion will be minimal. So don't write down like that. So even if it is 5 centimeter, in the exam, you can even present it as 2 centimeter for coming to your conclusion as COPD or chronic bronchitis.
Yes, sir.
One more thing. So another very important thing is especially the CVS examination, look for P2 palpable and parasternal heave.
Yes, sir.
Yes, sir.
Invariably, these patients, if they have severe chronic bronchitis, so they invariably they'll have pulmonary vascular resistance increase, and that will produce a P2 loud and P2 palpable. And if they have right ventricular hypertrophy, they can have parasternal heave also. So what you do is such things, when you are presenting, you say P2 not palpable or P2 is not loud, and you have a pause there. Just wait for the examiners to react, or there is no parasternal heave. Because next question, you wait for the examiner to, grasp this, what you are telling, and let them ask a question there. So whatever you think that it is very important, you stress there, pause for a few seconds.
Yes.
Okay, sir.
So that, how you should present in the exam. That is what I'm trying to tell you. So if you had said that P2 not palpable, and you have a pause, or if suppose P2 is palpable, then the next question is, why are you interested in that? Okay, suppose let us say that in this patient P2 was palpable and also P2 was loud. What is the importance for you?
That means that right ventricle hypertrophy is there, sir.
So right ventricular hypertrophy, parasternal heave has to be there.
Yes, sir.
P2 palpable, P2 loud is only pulmonary hypertension.
Hypertension, pulmonary
Yes.
hypertension.
It is not, it will end up with right ventricular hypertrophy later.
Yes.
Isn't it? So suppose if P2 is loud, and that shows that the patient has a pulmonary hypertension. Wow, how do you classify pulmonary hypertension? If you can measure the mean pulmonary arterial pressures.
Mean arterial pressure should be more than 50 millimeters of mercury, sir.
No. How do you classify MPAP? Based on MPAP, mild, moderate, and severe pulmonary hypertension. Because that also you should know.
Yes, sir.
It is, if it is less than 25 millimeters, but more than 18 millimeters, definitely it is on the higher side.
Yes, sir.
25 to 35 is mild. 35 to 45 is moderately severe. Anything above 45 millimeters of mercury of PaO2, sorry, MPAP, I'm talking about. Mean pulmonary arterial pressure, it is severe. If you say it is 50 millimeters, definitely it is severe pulmonary hypertension. So that is why you should know about this also. And if suppose the patient has pulmonary hypertension, severe pulmonary hypertension, P2 is loud, P2 is palpable, right ventricular hypertrophy is also there. So why you should know about this?
It means that the patient may develop.
Patient corporal.
No, intraoperative major adverse cardiac events. Cardiac events I'm talking about. We're not talking about, PPCs, postoperative pulmonary complications. In a patient with, pulmonary hypertension, the patient is also more prone for major adverse cardiac events. So, and that means he'll have double problems. He'll have a high cardiovascular risk. He'll have a high pulmonary risk. Isn't it? So these are the patients who are at higher risk for us, as far as the patients are concerned. So that is what you have to be careful about. Okay. The other thing is you have done all these bedside lung function tests. Very good. So that should be a part of your examination as a finding. So all those you have written, just, you have to know about the importance of these tests. Suppressive breath holding test. What does it give you?
So cardiopulmonary.
Pardon?
It gets we get to know about the cardiopulmonary reserve of the patient, sir.
The cardiopulmonary reserve. So what is a normal breath holding test?
So normal breath holding, it should be more than 40 seconds, sir, in a healthy adult.
45 seconds, sir.
Okay, 40 seconds, fine. But when you say it is significant?
So less than 25 seconds, we consider it as impairment in the cardiopulmonary reserve.
So
less than 15 is considered very severe, sir.
Yes,
Less than
less
15
than
seconds.
15 seconds. So it is one of the very important tests for all patients. You can do this. And again, last time we had discussed this, and you have to keep your stethoscope over the neck of the
Over the
patient.
neck, yeah.
The patient is holding a breath. Some patients, without moving their chest, they can even take a breath in between. So that is very important. So breath holding test and single breath count is another thing. When do you say, it is, significantly reduced?
Less than 15, when the patient is not able to count 15
Yes, okay.
with a single breath, we consider it.
Okay, how do you classify these based on the number of counts he can do with a single breath?
So dyspnea index.
No, the dyspnea index is different. With single breath count only, suppose you are asking the patient to count with single breath. Suppose if you can count more than 15, you can say, of course it is decreased. Anything up to 50, one can count.
Yes, sir.
Yes, sir.
But 1-5, if he can count above 15, the patient will not have much problem as far as PPCs are concerned. If it is decreased to less than 15, then again it can be classified as mild, moderate, and severe.
Mild, moderate, and severe. 10 to 15 is mild, sir.
11
to
to
15. 11 to 15 is mild. 10 to 5, 6 to 10 is
10.
moderate. Less than 5 is severe.
Yeah, that is another thing which you should know so that you can even classify there. Because this patient has had a 13, so he has got a mild
13.
decrease, isn't
Mild.
it? Yeah, okay. Then dyspnea index is another thing. Again, dyspnea index is, how do you get the dyspnea index?
It is when we ask the patient to count up to 15, sir, the number of times he pauses to take a breath or in between counting that we count, sir. So when there is no pause to take a breath, that is grade 0, sir. That is not having dyspnea index is 0. That is reserve is good, sir.
Okay.
When he pauses for one time, then there is mild impairment, sir. When he pauses twice, then there's moderate impairment. More than 3 times, if he pauses, then the impairment is severe, sir.
3 is the grade 3 and more than 3 is severe. Mild, moderate, severe, very severe. That is the dyspnea index, okay, that you know. And then the Snyder's match blowing test is again important. What does it indicate?
It gets to know about the maximum breathing capacity of the patient.
The MBC. Okay.
MBC.
So suppose the patient can blow the candle more than 9 inches.
More than 150 liter per minute maximum
150
breathing
liters.
capacity, sir.
What is the normal MBC? In males
More than,
and in females?
in males, it is 80 to 120, sir. Sorry, sir. In females, it is 80 to 120. And males, it is 100 to 140, sir.
No, males 150 to 200 and females 100 to 150. So as long as it is more than 100, the patient has got good maximum breathing capacity. And again, what is the indication? Suppose maximum breathing capacity is decreased. What does it indicate?
So the vital capacity.
No, vital capacity is different. Maximum breathing capacity is different. What define maximum breathing capacity?
The amount of air a patient is able to inhale and exhale in 1 minute, sir.
Is it maximum amount or just amount?
Maximum amount of air.
That you should always tell. It is the, all these are dynamic lung function tests.
Yes, sir.
MBC, FEV1, FVC, peak expiratory flow rate, and then maximum mid expiratory flow rate. These are the dynamic lung functions, which are usually done using a spirometry.
Yes, sir.
Isn't it? So maximum breathing capacity is a dynamic lung functions. Any dynamic lung functions, effort is important, the patient's effort and the timing is important.
Time dependent.
They are timed and then effort, the force with which they have to be done. So that is the difference between static lung function tests and then dynamic lung function tests. MBC is a dynamic lung function test. That's why when you are defining, you have to say the maximum amount of air a patient can inhale and exhale in 1 minute. And usually you do it for 15 seconds because the patient will not be able to continue for 1 minute and you extrapolate 60 seconds. So that is maximum breathing capacity. By knowing FEV1, can you know what is the maximum breathing capacity? Suppose, in spirometry, you don't get maximum breathing capacity, but you get FEV1. Suppose I know the FEV1 of the patient. how much I know I can calculate as MBC.
We can calculate. Not sure.
It is actually 3 to 5 times the FEV1 is maximum breathing capacity. 3 to 5 times. So, sorry, 35 times, not 3 to 5 times. 35 times the FEV1 is maximum breathing capacity. So that also is an exam question you should be knowing about. Okay, and then cough test, Green and Birowitz's cough test. So what is the inference from that?
It gives us the patient's ability, strength, and effectiveness of cough, sir. So where the one?
Yeah, if the patient is able to cough well,
more than 3 vital capacities is required for producing an effective cough, sir.
Okay.
And one more thing we can find is if the self-propagated cough is there, it means patient is having wet lung conditions. So then
no, not the wet lung, hyperactivity.
Hyperreactivity.
Yeah, it continues with multiple coughs.
Yes.
So you can say
one cough leads to the other successive cough means
hyperreactive airway, and because irritant, there is irritation. That is the reason why the patient is having a successive bouts of cough. And what is the FEV1 and FVC if the patient is able to cough well?
So the patient is able to cough and means the FEV1 is more than 20 ml per kg.
FVC is more than 20.
FVC is more than 20. FEV1 is more than 15, sir.
Yeah.
And the peak expiratory flow rate is more than 200 liters per minute. Sir.
Yes. This is very important. What is the normal peak expiratory flow rate?
So in males, it is 450 to 700 liters per minute, sir. In
400 to 700 liters per minute.
Liters per minute. And in females, it is 350 to 450 liters per minute.
Yeah, 300 to 500 liters per minute. So what is the importance of these, PEFR? Why should you know about PEFR? PEFR, when a patient wants to cough, when a patient wants to cough, so you'll have to take a deep inspiration and then forceful expiration. That is what is cough. Yes, and the force with which the expired air is coming out, that is the peak expiratory flow rate. Yes, so if we can have a good PEFR, that means he'll have a good ability to cough. Yes, vice versa also. That means if the patient has got good ability to cough, his PEFR is good. And if his PEFR is good, so he'll not have much problem in the postoperative days because ability to cough is most important. If he can cough well in the postoperative period, he'll not develop any PPC. Yes, sir. Yeah, preoperatively, if he can cough well, postoperatively, he should be able to cough reasonably well. So that will bring out all the secretions, so the patient will not develop any postoperative pulmonary complications. So that is another very important thing. And again, one more thing is, forced expiratory time, as you have written, it's more than 6 seconds means normally how much?
Normally it is less than 4 seconds.
Normally less than 4 seconds. So it shows that the patient has got an obstructive airway disease or not. Okay, that is one more thing. So one more thing is you have to ask the patient to take deep breaths and auscultate over the interscapular area. There is one more test is there. So Peace test. If you find a lot of subsequently, first the breath, there may not be any rhonchi. Subsequently, there are more rhonchi you can hear. So that means there is a narrowing of the airway. Subsequently, when the patient is taking deep breaths, collapsing of the airways is occurring. So that shows that the patient also will have a hyperreactive airway disease. So you have to be extremely careful. These are the patients who are likely to develop perioperative bronchospasm. So these are some of the things as far as the examination is concerned. And I told you about pulmonary hypertension as far as CVS is concerned. That is the most important thing in a respiratory case. Yes. Of course, the palpation, if the patient has carpulmonale, look for tender hepatomegaly and pedal edema and raised JVP. So
Hi, Jay.
things. Okay, now we know that this patient does not have much of actually COPD based on your findings. So he has a mild COPD. So let us say whatever it may be, what are the investigations you would like to do? Because this patient is being posted for laparoscopic cholecystectomy. So what investigations you would like to do and how do we proceed further?
I'll go ask for first hemoglobin, sir.
Okay.
Complete total blood count. And
yeah, you expect a hemoglobin high or low? Already
high, sir. High, sir.
High hemoglobin you expect, right? Suppose if
And
the hemoglobin is 17 grams,
yes, sir.
any problems you expect or you are very happy?
No, sir. So we need to correlate with the hematocrit, sir. And we'll also see if it's the.
No, hematocrit will be 3 times the hemoglobin.
Yes,
That is what? If whatever the hemoglobin is there, you just multiply with 3, you get, it will be more than 50. What is the problem you expect for the patient?
Viscosity is there, so they are more prone for hyper viscosity is there, sir. So
that
we have to provide adequate.
Yeah, DVT. So you'll have to go for
Yes,
DVT prophylaxis in these patients. So either you go for even including, prophylactic low molecular weight heparin, and then you can even have stockings for the lower limbs, because laparoscopic procedures, there is increased incidence of DVT because head up position and, stagnation of the blood. So that is what, every investigation is important, and you can be asked a question on that. You cannot say, okay, 17 grams, it can be there. You cannot be happy. Oh, no problem. He has got, he can lose a lot of blood because, his amount of blood loss, maximum available blood loss can be very high if he has got 17. But, he is prone for DVT, and DVT can produce pulmonary embolus, and already a patient with pulmonary problems, may be having a chronic carpulmonale superimposed with acute carpulmonale can occur.
Yes, sir.
You are following, isn't it? So
Yes,
that also will be very important. Okay. Then other than hemoglobin, what else?
So total counts and differential counts.
Yeah, in the total count, what is important again?
So look for any, if the counts is raised, means the patient will be on any active infection, and look for a neutrophils count.
Okay. So one is infection you want to rule out, because if he has got an infection, so you cannot take him up for surgery. That is one thing. Okay. So does the infection come in any risk indices? Any particular risk index?
Ariscat.
Ariscat, yes, very good. So what is this Ariscat risk index?
Ariscat is assessment of
expansion of Ariscat.
Assessment of respiratory infection in Catalonia group.
Not respiratory infection.
In surgical patients in Catalonia.
Catalonia. It is assess respiratory risk in surgical patients in Catalonia. Why this Catalonia? See how questions can be asked for you in the exams. That is what I'm trying to prepare you for the exam only. Catalonia is in Spain. So in that particular hospital in Catalonia, actually, this was introduced in Catalonia hospital. So this particular Ariscat risk was introduced. So that is why. So can you just tell what are the factors in Ariscat?
Age, sir. Age, preoperative saturation, respiratory infections prior in the month.
Yeah, within month, not
within
prior. Within month. That's what I tried to ask you now. Because if the patient has presently infection, so usually how much of the scoring for patient having a infection presently? How many points are given?
18 points.
Huh?
17 points.
Yeah, 17 points.
17 points.
Very good. So for age more than 80 years?
For age
16 points. More than 80 years. Okay. Saturation less than 90%. Very important. Again, how much?
Yes,
how many points? 24 points.
24 points, yes.
Saturation. Anemia less than 10 grams. Now that also hemoglobin now, just now we see that.
Yes,
If
sir.
the hemoglobin is less than 10 grams, so what do you say, how much?
Around again 60.
Again, 11 points, 11 points. And next is, the surgical things.
Site of surgery. Upper
Yeah.
abdominal.
Site of surgery, again, very important. If it is intrathoracic, how much?
Sir, 20 points.
24.
24 points.
If it is upper abdominal,
16 points.
21 points, 21, 24. So these are the patients who are likely to develop postoperative pulmonary
Pulmonary
complications.
complications.
Another is duration of surgery.
Duration of surgery.
More than 4 hours.
Yeah, more than 3 hours. High risk,
Yes.
more than 3 hours. Again, 24 points.
Yes, sir.
Okay, then emergency surgery.
Emergency surgeries.
How many points?
17 points.
8 points. So, because, in theory also you may have to write. So, total points will be about 123 points. So, you should be almost memorizing these things. Because RSCAT score is one thing. I don't know whether in your hospital, the pulmonologist, are they doing this RSCAT scoring for patients posted for surgery?
No, sir. We haven't seen.
No, in our hospital, they are doing this score only.
Yes, sir.
Whenever we refer them, they write down what is the RSCAT score.
Yes, sir.
And these they need not have to do. You can also do.
Yes, sir.
All these are very, very simple to know whether patient has got anemia, what is the age of the patient, whether he has got respiratory infection within 3 months, what is his saturation, and site of surgery, duration of surgery, emergency surgery. So you can also score. It is better you start doing that, another 1 or 2 months you'll be there in the hospital, you'll be working. So start doing RSCAT scoring for all patients with respiratory diseases.
Okay.
Yes, sir.
So then, again, how do you know that which of these patients are at high risk based on RSCAT score?
If it score more than 45, they can categorized as high risk.
Very high risk, sir.
Correct. So less than 26 to 44 and 45 and above. High risk
Yes.
for 45 and above. So it's a very easy and a simple scoring system. So you should know for exam purpose also, and for regular day-to-day, you can manage with this. Okay. Now we were talking about the investigations. So again, complete blood count you were talking about.
Yes, sir.
Okay. One is infection. Another thing is AEC, absolute eosinophilic count.
Eosinophilic count.
So when do you think that the patient will be at high risk of intraoperative bronchospasm?
When the eosinophilic count is raised because of the asthma associated, they can have ACO, sir.
Now, how much raised?
Don't know, sir.
So it should be, if it is more than 500, so then you know that patients have increased the risk of perioperative bronchospasm. So that is another very important thing you should always know about AAC. And also other thing is, because you are in Pondicherry, you are in a coastal area, what else is important as far as respiratory problems and eosinophilic count? What is tropical eosinophilia?
Tropical eosinophilic.
Yes.
What is, when do you say tropical eosinophilia? Because this is another thing which you have to rule out in these patients when they have come to you with respiratory infection and for surgery.
What is?
It is more than 2000 is tropical eosinophilia. AEC more than 2000, and it is very common in coastal areas. Microfilariasis. Microfilariasis is very common in coastal areas, so you have to be careful. And we even when I took my exam, I studied my MD in Mangalore. Again, Mangalore, it is very common. So I was asked, how do you treat? How do you treat tropical eosinophilia? So what is the drug that usually you give? So you see that the same thing was asked to me in the exam also. So Hetrazon is one of the drugs. So of course it is a trade name. So usually you go for Hetrazon. So that also you should be knowing. Okay. So let us move on to the other investigations.
So, RFT and serum electrolytes, urea creatine serum electrolytes.
Okay.
And
again,
I also asked for
RFT means renal function test, is it?
yes,
Yes,
So I told in the last this thing only sessions only, don't mention short forms.
yes. Serum urea creatine.
It can be respiratory functions test also, isn't it? So you say renal function test, and why a renal function test is again important. Again, creatinine is
increased serum creatinine.
yeah, again important.
Again,
In more than 2 milligrams, again is another very important thing.
risk factors
That is
for
for the pulmonary complications. Okay, okay. Then
serum
liver function
test,
test,
we go for serum albumin. So
albumin less
less
than
than 3.5 gram per deciliter.
yes, yes, correct.
Chance for most of post-operative complications.
Okay, that is also one other thing, right? Then what other
ECG is ECG
Okay.
chest X-rays.
Okay, okay. ECG, right?
Electrocardiogram. And
So what you will be finding in ECG?
so it will be tall P waves in the lead to so P pulmonary. So
Yeah,
look
P pulmonary.
for signs of RVH.
right ventricular hypertrophy.
Hypertrophy.
Okay,
Tall P waves in the lead 2 and RS ratio more than 1 in lead V1 and V2, sir.
okay,
And
okay,
low voltage QRS complexes and poor RV progression.
okay,
And
okay.
rate acceleration.
Right, right. So that is very important as far as ECG is concerned. Okay, what other lab tests, investigations?
Chest X-ray.
Chest X-ray.
Chest X-ray. So routinely should you ask for chest X-ray?
So if there's in the examination itself, if you're able to confirm the diagnosis, it's not necessary to expose the patient for chest X-ray.
Correct. So unless you think that there is a possibility of pneumonia or lower respiratory infections, then only, or even many of these patients can be 70 plus.
Yes.
So in such situations, you can ask for a chest X-ray. Otherwise, routinely don't ask for chest X-ray. Okay. Then more investigations. So
Echocardiogram based on
echo, okay. Suppose if you think that P2 palpable, parasternal heave is there, then you want to know exactly what is the mean pulmonary arterial pressures or pulmonary systolic pressures. So that's how you require to know about the right ventricular status also. So you can always ask for a echocardiogram. Okay. Then lung function tests.
lung function, PFTs.
So definitive lung function tests, especially spirometric lung function tests. So what are the indications for spirometry in these patients?
Sir,
So spirometry. For this patient, since it's an abdominal surgery and also under laparoscopy, so we need to know about the baseline lung mechanics.
No. What are the indications for spirometry as such?
So as upper abdominal surgery.
The indications will be any thoracic surgeries.
No, first of all, I'll give you a clue. How do you know that this patient has got COPD? Is COPD is a clinical diagnosis or spirometric diagnosis?
So ratio we need to find. Confirm the diagnosis of COPD. So
Isn't it? It is always a spirometric diagnosis. That is why, if you are in doubt about whether the patient has got COPD or not, so subject the patient for spirometry. That is an indication. When you say a patient has COPD based on FEV1 by FVC ratio,
Less than 80.
less than 0.7.
less than 0.7. FEV1 should be less than 70% of the FVC. Less than 0.7 ratio between FEV1 and FVC, then you say that patient has COPD. So that is for diagnosis of COPD, you require spirometry. What else?
Yes, sir.
What are the other indications for spirometry? Now you see what is the gold classification of COPD based on FEV1 and FVC ratios. Gold.
Grading of COPD. Sir.
Mild, moderate, severe, very severe, sir.
Okay, how do you grade based on the
So
FEV1?
mild, yes, sir. Mild based on FEV1, sir. Mild COPD is less than 80% of the predicted value, sir. Moderate is
predicted FVC. Is you see normal. This thing is, of course, as you said, less. You have already diagnosed the patient to have FEV1 by FVC ratio of less than 0.7.
0.7.
yes,
You have diagnosed, of course. Now, what is the predicted FEV1 he has? If it has got more than 80% predicted FEV1, it is mild, right? Moderate.
50 to 80 is
50
moderate.
to 80 is moderate, sir.
Very good. Then
Severe is 30 to 50, sir. Less than 30 is very severe.
yeah, now Gold's classification is very, very important to know whether what is the severity of the COPD, isn't it? For getting the severity of the COPD, what you require?
Spirometry.
Spirometry. That is another indication.
Yes, sir.
First indication was diagnosis itself.
Diagnosis of
Second thing is to assess the severity of the COPD, because more the severity, more chances of these patients developing PPC and more time they required for preparation. That is why Gold's classification of the severity of the COPD based on FEV1 and FEV1 is very, very important. So that is the second indication. What is the third indication for spirometry? No, I will give you a clue, because you were telling in the beginning the definition of COPD, whether the patient may have a partially reversible or irreversible as far as bronchodilation is concerned. So you have to know whether bronchodilatory drugs are effective or not.
Yes, sir.
So you have to do a pre-bronchodilatory FEV1 and post-bronchodilatory FEV1. When do you say the bronchodilators will work? How much increase
When
in
there is
FEV1?
when there is greater than 20% increase in the
More than 15%. More than 15% increase in FEV1 post-bronchodilator, you know that the patient will respond to bronchodilator therapy. Otherwise, unnecessarily, you'll be giving bronchodilator therapy. Already we have discussed the problems associated with bronchodilator therapy, isn't it? So you'll have to prove that the patient definitely will get benefit out of these bronchodilators. So again, another indication for spirometry. No, it's the third indication. What is the fourth indication? No, another clue I'll be giving. So you have a patient with COPD, you are going to prepare the patient, isn't it? Now, how you know whether it is effective preparation has been done or not?
yes, sir.
So you have to compare with basal spirometric findings and then post-preparatory spirometric findings. There should be some good difference between basal and after your preparation, isn't it? So for that, unless you do a spirometry, how do you know whether he has improved or he has not improved? So that is another indication for preoperative spirometry. What else? Suppose another clue I'll give you. Suppose this patient is posted for a lung resection surgery.
predicted post-operative.
Predicted post-operative FEV1.
Isn't it? So PPO FEV1 for calculation, you require spirometry preoperatively. So these are the 5 indications for preoperative spirometry. And another thing also, you can say you are in doubt whether the patient has got obstructive pulmonary disease or restrictive pulmonary.
Yes,
So in order to differentiate, you can always get a spirometry done.
yes.
Then you know whether it is obstructive or restrictive. What happens? How do you differentiate?
So FEV1 by FVC ratio will be more than 0.7 in restrictive, sir.
It will be normal. You can say normal. So here it is less than 0.7.
Yes, sir.
Isn't it? In obstructive. So that is how we know there is a most important principal difference between obstructive lung disease and restrictive lung disease.
Restrictive.
Other differences are there, like, total lung capacity is very important. Total lung capacity
reduced.
reduced in
Restrictive lung
sir,
disease.
restrictive.
Can you, classify restrictive lung disease based on the total lung capacity compared to the predicted value? How do you classify restrictive? For example, you may get a restrictive lung disease patient, interstitial lung disease patient for your exam. Don't expect always COPD patient only. So then you'll have to think about all restrictive lung disease and the problems associated with that. Because majority of the things are common for all respiratory disease patients. Your preparation, their postoperative pulmonary complications almost are similar. Only thing is restrictive lung disease patients will have more of hypoxemia, hypoxemic lung failure rather than ventilatory lung
Ventilatory
failure.
lung failure, yes.
Because their alveolar capillary membrane is very thick. Gas exchange is a problem. They may not have hypercarbia. They have hypoxemia. So type 1 respiratory failure is more common in restrictive lung disease compared to obstructive lung disease where ventilatory failure is more common. So based on the total lung capacity, suppose if it is more than 65% of the predicted, so it is almost say mild restrictive lung disease. If it is 50 to 65% of the total lung capacity of a predicted value, it is moderate. And if it is less than 50% of the predicted total lung capacity, it is severe. So more than 65%, 50 to 65%, less than 50%. So just remember about this. You can also classify restrictive lung disease severity based on the total lung capacity, which will be decreased. Okay, so these are some of the indications for spirometry. So invariably, majority of the times, spirometry is conducted for all the patients with respiratory disease, but it is not required. It is not required. So unnecessarily, it may be charged for about 1,000 rupees. It may be charged for the patient. When you know that the patient does not require, and if these indications are not there, don't ask for spirometry unnecessarily. Okay, that is the thing about asking for spirometry unnecessarily. Okay, now we have done most of these investigations. So you should know about the static lung function test. You may be asked about, suddenly they must start asking about static lung function test, dynamic lung function test, non-metabolic functions of the lung also they can ask you. What are the non-metabolic functions of the lung?
So you need lung condition, sir.
Pardon? Non-metabolic functions of the lung. Now, one is metabolism of the drugs like propofol. 25% of propofol gets metabolized in the lung. So it also metabolizes other drugs. That is one metabolic function. That is a non-respiratory function. I said non-metabolic function, is it?
Metabolic.
No. Non-respiratory functions of the lung. So metabolic function, that is mainly, metabolism of drugs like propofol. The second thing is, your ACE.
Conversion of angiotensin 1.
Angiotensin converting enzyme is present in the lungs, isn't it? So the conversion occurs there only from angiotensin 1 to 2. That is the second metabolic function of the lung. The third is, it is very important for maintenance of fluid balance in the body. You must have seen, if you are, through respiration, a lot of fluids are excreted.
Yes.
Because moisture content is there. So that's how, lung also takes part in fluid balance the body. One more is temperature regulation.
Yes.
So when you start running, you produce so much of heat energy. So you will start, puffing so that you are releasing heat energy also from the lung. So temperature regulation. So it is temperature regulation, fluid regulation, and also in metabolism of certain drugs like propofol, and also for conversion of angiotensin 1 to angiotensin 2. So these sometimes they may ask non-respiratory functions of the lung. Just remember about. Okay, now coming to the preparation of this patient. So how do you prepare this patient? Now, one more investigation we have not discussed is ABG.
ABG.
Yeah, ABG is another very important investigation. One is ABG, another is, diffusion coefficient of
DLCO,
transfer, DLCO, diffusion factor for
carbon monoxide.
carbon monoxide of the lung.
Yes, sir.
Okay, so ABG is very important. Again, why ABG is important?
So we'll be able to find out what is the baseline PCO of the patient, sir. So we'll be able to know the degree of the severity of obstruction, sir.
Okay,
And,
let us say that. Okay, continue.
If the PCO2 is high, then we have to adjust our ventilatory strategy so that we don't cause metabolic alkalosis by hyperventilating the patient, sir.
Very good, very good. One, right. Then, what are the other things? Suppose if the PaO2 is on the lower side, you must have known about Nunn and Milledge classification.
Nunn and Milledge criteria.
So just remember about Nunn and Milledge. In all those patients with severe decreased FEV1 respiratory cripples, whom you call respiratory cripple? Which patients you call respiratory cripples? Based on your board's classification.
Sir, gold 3 and 4.
Very severe. No, very severe.
Very severe.
So less than 30% of the FEV1 predicted, they are called as respiratory crippled patients. Usually they have FEV1 of less than 1 liter. That is what, Nunn and Milledge's classification. Patients with less than 1 liter of FEV1. So if their PaO2, PaCO2 is normal, they may not require any oxygen supplementation. If PaO2 is on the lower side, PaCO2 is normal, they do require
Postop oxygen supplementation.
Yeah, PaCO2 is also high.
Postop mechanical ventilation.
Yeah, mechanical ventilation, isn't it? So that is very important. And what is the importance of DLCO?
Sir, we'll be able to know the diffusion capacity, sir. If it is reduced, then there is oxygen transport from the alveoli to the capillary is also impaired, sir. So
that is more common in restrictive lung disease, isn't it? Decreased. Yes. So again, this is very important to even know predictive post-operative DLCO. Like
yes,
PPO, FEV1 you had calculated. Like that, PPO, DLCO is also very important. Normally, it should be more than 40%. Suppose if PPO, FEV1 is less than 40%, but PPO, DLCO is more than 40%. So these patients can be extubated on table for lung resection surgeries. That is the importance of.
Yes, sir.
So that is also another important thing you should know about. Okay. So again, sometimes we asked about 3-legged stool tests. These investigations, pulmonary investigations can be classified as 3-legged stool test. So why this is 3-legged stool is called as?
The various interactions we will be
examining. Why it is called as
mechanics? That is the.
No. One thing, Ramanathan, why it is called as 3-legged?
3 components.
3 components are there, but why 3-legged stool? Why you call it as 3-legged stool? Why Miller has coined this particular name? No, you have stools in your OT where anesthesiologists.
Yes, sir.
Now, how many legs they will have?
3, sir.
3 legs, isn't it? You are so familiar with 3-legged stool. That is, probably in Miller's. It's only given in Miller textbook of anesthesia.
Yes.
So because 3-legged stool is so familiar for anesthesiologists, you can move around, isn't it? You can rotate. So it will contain 3 legs. So that is why 3-legged stool. So mechanical functions, parenchymal functions, and cardiopulmonary reserve. Are very, very important. So we have discussed mechanical functions, FEV1, FVC, FVC. Then parenchymal functions, blood, arterial blood gas and DLCO.
PO2, PCO2 and DLCO.
That is arterial blood gases. So third thing is the reserve capacity, cardiopulmonary. So one already we discussed few of the things in bedside. So any other tests that are done, you can do it in your hospital also. To know
6-minute walk test.
what is this
6-minute walk test, sir.
Yeah. What you can gain by doing 6 minutes?
VO2 max we will be able to find out, sir.
Yeah, VO2 max. So how do you calculate VO2 max from 6-minute walk test?
So the distance covered in 6 minutes divided by 30, sir.
Mean meters.
In meters divided by 30.
Divided
Yes,
by 30, you get the VO2 max. Okay, that is one thing. Again, second thing is staircase climbing test.
yes, sir.
Isn't it? How many flights of stairs the patient can climb? So VO2 max, you can always calculate on that also. And the third thing is incremental shuttle
walk test.
Yes,
No, because if you don't have so much of space for the patient to walk for 6 minutes, you can make the patient to walk in between fixed 2 points.
yes, sir.
Shuttle
10 meters apart.
in between. That is called as incremental shuttle test.
Shuttle.
And there is a software for that. And there is a music is also there. Music starts becoming faster as the patient.
Yes, sir.
So he has to shuttle faster and faster
Yes, sir.
after some time. So that's how, it is calculated how many number of shuttles he can make between probably about 10 or 11 meters in between. So that is incremental shuttle walk test. So this is also one of the tests that can be done. Okay, now coming to the preparation. So what are the things you will be looking for as far as the preparations for these patients are concerned?
Sir, as of our patient is concerned, since he's a chronic smoker, the option will be to cessation of smoking, sir.
Correct.
And if he's on also bronchodilator therapy, so I'll ask him to continue it. And if also correct the hydration status, and if there is any electrolyte imbalance, that has to be corrected, sir. And mucolytics for loosening of the secretions along with hydration, sir.
You can
and
say
then I'll encourage him to chest physiotherapy, deep breathing exercises, and also
including
for incentives
mucolytic agents and mucokinetic agents.
Yes.
So, and incentive spirometry is very important. Nowadays, it is routinely given for cardiac patients and also respiratory disease patients. And
Yes.
another thing is lung expansion maneuvers.
Many years. Ask him to cough and breathe.
These are the things are you have to do. They are also called as prehabilitation maneuvers for preparing these respiratory disease patients. So preparation is very important. So you'll have to talk about the different methods of preparation, including, the
Psychological
nourishment. Many of these COPD patients are extremely frail. They are very thin. They would have lost a lot of weight. So you will have to really give them high protein diet for at least few months before taking up for surgery, so that they'll be able to cough well. Because, poor nutrition, the muscle mass will be very less. They'll not be able to cough well. So that is another reason why you have to prepare. Suppose another thing is if they are having, failure, so you have to treat them for failure before taking up for respiratory failure as well as, cardiac failure.
Yes, sir.
You have to really treat them before taking up for surgery. Okay, now coming to the anesthetic management of these patients. You have prepared these patients, okay, prepared them well. That is why, in ARISCAT score, emergency surgery is there. One of the factors that is looked for in ARISCAT score. Because, whenever they are posted for emergency surgeries, you don't have time to prepare these patients.
Yes, sir.
So then you'll have a lot of problems. So they do develop postoperative pulmonary complications. So that is why it is very important to prepare these patients. You should have enough time to prepare these patients. Okay. So now coming to the type of anesthesia, what you want to give. Which type of anesthesia would be better for these patients?
Regional anesthesia would be better, sir, if possible.
If possible, regional anesthesia, because the incidence of postoperative pulmonary complications can be much less with regional anesthesia, because the ability to cough well in the postoperative period will be preserved if you take them off regional anesthesia, especially peripheral regional anesthesia, like brachial block or sciatic nerve block. That will be very ideal. And also you can go for central neuraxial blocks. So they are also very good. Either you can go for spinal anesthesia or epidural. So, suppose you have a choice between spinal and epidural, which one you would like to go for?
Epidural.
Epidural.
What are the problems with spinal anesthesia?
Sir, achieve level of more than T6 might impair the expiration of the patient, sir. The patient will not be able to entirely expire. So CO2 retention might increase.
Okay, that is one thing. And what about the coughing?
Coughing will ascend the level.
Coughing, what is the important muscles for coughing? Diaphragm for inspiration. Abdominal muscles. What happens to the motor blockade of the abdominal muscles? There will be motor block, isn't it?
Okay.
And
So
it can continue also. Motor block, many times you must have seen, maybe 3 hours, 4 hours. Surgery is over in half an hour, you have given spinal, but till 4 hours, the motor block, abdominal muscles have not regained the power. Patient is not able to cough well, so he'll succumb to postoperative pulmonary complications. So don't think that your regional anesthesia is always very safe. And one more thing, when you give spinal anesthesia or epidural for that matter, what happens to the pulmonary blood flow?
Blood flow increases.
Decreases.
Yes, sir, decreases.
Decreases.
With spinal epidural,
It increases, sir. Sorry.
decreases, isn't it? Because peripheral pooling of the blood. So right ventricular blood preload will come down. And
Yes, sir.
right ventricular blood only has to go to the pulmonary vessels. So with all epidural and spinal, the pulmonary blood flow decreases. If pulmonary decreases, what happens to the dead space?
Dead space increases.
So if the dead space increases, what happens to the carbon dioxide retention?
Retention happens. There is more carbon dioxide.
More of CO2 retention.
More retention occurs. So these are the things which you also should know. That, don't think that your spinal or epidural are absolutely safe. They can also produce problem. But advantage of epidural is one thing is, it is a segmental block. And motor block is not so when compared to the spinal anesthesia.
Yes, sir.
Motor block will not be very good in epidural. And third thing is, you'll be using larger amount of local anesthetics, which can help in bronchodilation.
Yes, sir.
So that is another advantage. Suppose if you are using adrenaline along with local anesthetics, that also is going to help in bronchodilation. So the multiple advantages are there with epidural. So you can always come, plus analgesia, good analgesia, so that the patient can cough in the postoperative period.
Yes, sir.
So you should always combine, if you are planning for upper abdominal surgeries, open surgeries, you should always give, put an epidural catheter of analgesia as well.
Yes, sir.
So that is another very important aspect. Well, how about brachial block? Is it very safe in patients with bronchial asthma and COPD patients?
No, sir. When we give intrascalene block, if the phrenic nerve is also blocked, then it might impair the patient's ability to cough, and respiration is affected, sir.
Yes. So that is intrascalene block. What is the incidence of hemidiaphragmatic palsy with phrenic nerve? Sorry, with intrascalene block.
Around 40 to 50%. It's very high.
It is nearly 100%.
Yes, sir.
Unless you go for truncal blocks. Selective truncal blocks, they almost minimal, the phrenic nerve block occurs. If you are planning for example, shoulder surgeries. Shoulder surgery, you can even go for truncal blocks.
Yes, sir.
So upper trunk and middle trunk block, enough.
Yes, sir.
C567 is more than sufficient because this is supplied by C567.
C5 and 6.
So with use of ultrasound, I think in your Dr. Siva is there, specialist and authority in as far as ultrasound guide the brachial blocks. So you people must be practicing truncal blocks, isn't it?
Sir.
So that is another thing which you should always remember. You can definitely go for a truncal block, whereas supraclavicular or infraclavicular blocks, supraclavicular again 50% chances of traumatic palsy. But
Yes, sir.
intraclavicular hemidiaphragmatic palsy is very minimal.
Yes, sir.
Axillary, it is not there. So like that, you can choose a particular technique of brachial block.
Yes, sir.
The problem that I have noticed, I have had about 4 patients after interscalene and supraclavicular block. They have gone for severe bronchospasm. And then I actually searched in the literature. There are, incidences that have been quoted in the literature. Is supraclavicular and interscalene blocks producing severe bronchospasm, especially in those patients with respiratory infection and also patients with hyperactive airway disease. Because, you are going to produce sympathetic blockade of the bronchi and bronchioles.
Yes, sir.
Yes, sir.
When you are producing sympathetic blockade of the bronchi and bronchioles, unopposed
Parasympathetic action.
on the bronchi and bronchioles can produce, this kind of bronchospasm intraoperatively. So don't expect the interscalene or supraclavicular block to be very benign as far as these respiratory disease patients are concerned. You can land up with problems, isn't it? So that is why it's always better to go for an infraclavicular brachial block or an axillary brachial block in these patients, which may not produce these kind of problems.
Yes,
Okay.
sir.
Regional anesthesia is always better for these patients compared to general anesthesia. Again, in the general anesthesia, should you go for general endotracheal anesthesia or general anesthesia using a supraglottic airway device?
Supraglottic airway device is
Reduced respiration. Yeah, because the supraglottic airway device may not produce so much of stimulation
to
the airways compared to your endotracheal.
device.
Definitely, you can choose for a supraglottic airway device. So these are some of the things which you should always think about when you are planning for anesthesia in a patient with respiratory disease patient. Okay. Now, what you are planning for? Now, for this patient with lap cholecystectomy, what anesthetic technique you are planning for?
So
General anesthesia, sir.
and
With
endotracheal intubation.
No, you want to go for endotracheal tube or supraglottic airway device?
Endotracheal.
Supraglottic airway device is fine.
So, but ours is a laparoscopic surgery, no, sir.
Yeah, let it be laparoscopic surgery. You have not done laparoscopic, especially cholecystectomy under supraglottic airway device. It is done, so many of them are being done using, especially generation 2, second generation supraglottic device, like Basca mask or your ProSeal LMA or even Supreme LMA or iGel. They're routinely used for lap cholecystectomy. So why do you want to go for an intubation for these patients? You have to reason out. There is no problem in telling that, no, sir, okay, I want to go for only general endotracheal anesthesia. But only thing is you have to reason it out. Yes, because we know that supraglottic airway devices definitely will produce less incidence of laryngospasm, bronchospasm, and all postoperative pulmonary complications. So why not?
Sir, in laryngoscopy, there is, in laparoscopy, there is increased risk of aspiration, sir. So
aspiration, elective procedures, you don't expect aspiration. It's an elective procedure. You're taking with the patient stomach empty. Why do you think that aspiration can occur?
Patient will be on a spontaneous ventilation.
No, you need not be. Supraglottic airway device, you cannot control ventilation, isn't it? Is it?
you can.
Yes, sir. Now, what is the problem in COPD patients? Why supraglottic airway? You have to reason it out, isn't it? Now, okay, one thing I tell you, what happens to the resistance for ventilation in COPD patients?
Increase.
There is increased resistance, isn't it? They have got a narrowed airways. That is what airflow limitation. Already we have discussed about chronic, persistent, progressive airflow limitation in these patients. Yes. So suppose if they have an increased airway resistance, what happens to the peak airway pressures you have to produce?
It will be very high, sir.
The peak airway pressures will be increased. But plus, when they produce new peritoneum, what happens to, again, the peak airway pressures?
Further increase. So if peak airway pressures are increasing, what happens to the leak around your supraglottic airway device?
It is also, there will be more leak.
It's going to be an increased leak because, what is the cuff leak pressure will be exceeded.
Yes, sir.
or pharyngeal leak pressure or pharyngeal seal pressure will be exceeded when you are using a supraglottic airway device in a patient with COPD or bronchial asthma patient, especially for when the neoperitoneum is created. So more of the gases will be going into the stomach rather than into the lung.
Yes, sir.
That means the patient will be hypoventilating, plus there is, increased inflation of the stomach. Surgeon will not be able to operate.
Yes, sir.
Did you agree?
Yes, sir.
Yes, sir.
So this you have to tell that. Why you wanted to. Suppose if you have an endotracheal tube, this problem is not there at all.
Yes, sir.
Okay, another incident I'll tell you. Suppose these patients are highly prone for intraoperative bronchospasm. Suppose the patient develops intraoperative bronchospasm, can you ventilate with a supraglottic airway device?
No, sir.
Difficult.
Then why do you want to use
Risk.
supraglottic airway device?
Yes.
Isn't it? So you have to reason it out. You are correct in telling that I would like to go for an endotracheal tube only. So in laparoscopic, suppose the patient was posted for some infra-abdominal surgery where there was a contraindication for regional anesthesia, you had to go for GA. And then you would have gone for definitely a supraglottic device, isn't it? So you could have managed. And another thing you should always look for laparoscopic surgeries, you also should look for the surgeon. How long he is going to take? If the surgeon is taking a long time, better to go for endotracheal intubation rather than supraglottic airway device.
Yes, sir.
You understand?
Yes, sir.
So all those things you'll have to think about. Okay, you have planned for endotracheal intubation in this patient. Okay, now how do you proceed? You have visited the patient the previous evening.
Yes.
You have taken the consent. You have also taken, you have instructed the patient for nil per status. Okay, then.
Pre-medications, sir.
And also you have told him what all the drugs he has to continue.
Continue. Yes,
The
sir.
next day. So he has to continue with his nebulization or inhalation multi-drug inhalers. At least he should take 2 puffs of that and then before entering the OT, and also he should bring that into the OT.
Bring that
Bring it with him, along with him.
Yeah, why he should bring it into the OT?
Sir, in case of any intraoperative bronchospasm, we will be able to use the drug, sir.
Now,
And,
one thing is,
it will alleviate the patient anxiety also, sir.
yeah,
That
these two things are very important. Very good, very good. Okay. So those things are there, and he is on some antihypertensive drug once a day. Maybe what antihypertensive drug he would be? Beta blockers or calcium channel blockers or AC inhibitors?
Beta blockers is contraindicated in our patients.
Okay, very good. So that also you should know. Maybe he may be on a amlodipine, he may be on. Calcium channel blockers are very good in patients with respiratory disease and having hypertension. So he may be, because you said once a day, I did not go into details about that because of lack of time. So amlodipine, the patient may be on. So would you like to continue on the day of surgery?
Yes, sir.
Okay, suppose if he was on AC inhibitors, he could be on AC inhibitors also, or ARB.
For AC inhibitors and ARBs, we like to stop the drug 24 hours prior and start them on calcium channel blockers, sir.
No. Now things are changed. So only for major surgeries, you stop 24 hours before.
Yes, sir.
If you expect a lot of fluid shifts intraoperatively, then only you stop 24 hours before. In laparoscopic surgery, you can continue on the day of surgery. You need not have to stop. That is always there. ARBs or AC inhibitors. Okay. So, okay. Now, what pre-medicants you would like to give? Should you give anxiolysis previous night? Anxiolytic?
We can give anxiolytics.
No, can or should give?
We should give, sir, because again, catecholamines will stimulate, make the patient more prone for spasms. No.
Now, what happens? Suppose if the patient is anxious, how he breathes?
Short breath, sir, hyperventilate.
Isn't it? So he'll start, though you can say it is hyperventilation. So actually, his effective ventilation will not be occurring. Isn't it? So he may have develop hypoxia and hypercarbia. So it's very important that gas trapping will increase because, any hyperventilation. So tidal volume So because, number of times he's breathing more. So every time he does that, more gas trapping, air trapping will be occurring, isn't it?
Yes, sir.
So more problem as far as hypercarbia is concerned. So that is very important. And that's the reason why you have to produce a good amount of anxiolysis. Okay, you have done that also. Okay, then intraoperatively. So
Sir, our opioid of choice will be fentanyl, sir.
okay, so pre-medication,
Short-acting-
operative, pre-induction medications.
Yes, sir.
So what are the pre-induction medications?
Midazolam, sir. Go for 0.05
Okay,
mg per
okay, midazolam, I'm fine. Right, then,
I'll go with the short-acting opioid, sir.
okay, with
And, with fentanyl.
suppose you have ultra short acting,
Remifentanil, sir.
would it be okay?
Yes, sir.
But you have to give it as a
Infusion, sir.
infusion now, because the duration of action is only 6 minutes.
Yes,
Yes, sir.
So either fentanyl or if available remifentanil is definitely very good, because post-operative respiratory inhibition will be much less.
yes.
Using remifentanil, you can control definitely. Okay, okay. Then
And then for my induction agent of choice, drug of choice would be
what about dexmedetomidine?
yes, sir, you can use it.
Yeah, it's an ideal drug because you have to maintain deep plane of anesthesia because any lighter planes can provoke bronchospasm.
Bronchospasm.
So deep plane of anesthesia can be managed with when you are using dexmedetomidine, and also it produces bronchodilation,
Dilatation.
direct effect. Though it reduces the circulating catecholamines, but direct effect is bronchodilation, and also it suppresses the intubation response when you are doing. Stimulation of the airways will be much less. So development of laryngospasm, bronchospasm will be much less if you use dexmedetomidine. So definitely you can use dexmedetomidine as a drug for
Yes, sir.
pre-induction medication. Okay,
Yes, sir.
so these drugs you have given. How about lidocaine?
Yes, sir.
Lidocaine is
1.5
1.5
mg per kg, sir, to blunt the response to intubation.
Yes, especially he is a hypertensive patient. There are two methods. One is hypertensive, so sympathetic response to laryngoscopy and intubation you have to suppress. Then second thing is airway reflexes also you have to suppress. Because airway reflexes, if they are active, the patient can develop laryngospasm and bronchospasm. Hyperreactive airway problem is always.
Yes,
Okay, that's how lidocaine is very good. Then, okay, induction agent of choice.
Induction agent of choice will be propofol, sir.
Yeah, propofol, what are the reasoning?
So it is a good, it readily blunts the airway reflexes, sir. And it's also a good bronchodilator, sir.
Very good.
It's so fast, rapid on onset also.
No, both tapentone and propofol are rapid acting only. But only thing is airway reflexes are,
Airway reflexes are suppressed in.
and then sympathetic responses to intubation are suppressed.
yes.
Antiarrhythmic drug is,
Mm.
and post-op nausea vomiting is also.
Vomiting is also.
So bronchodilator also, direct bronchodilator. So multiple advantages with propofol. What about thiopentone?
Sir, it does not blunt the airway response as much as propofol, sir.
But also
And,
a histamine release.
Not histamine release. A more important thing is lighter planes of anesthesia of thiopentone. It sensitizes the airway reflexes. If you manipulate the airway, patient will develop bronchospasm.
Yes.
That is why there is a relative contraindication for thiopentone in patients with hyperreactive disease. So that is the reason you should not use thiopentone. Ideal would be propofol. Patient also having a carpulmonale,
Sir, then
Etomidate.
etomidate would be the drug of choice. So that's how you'll have to think about. And now, okay, now you start your anesthesia. You have given this pre-medicant drugs.
ఒకసారి లైట్ బంద్ చేస్తారు ఆన్ చేయి.
Pardon? Somebody.
some others unmuted, sir.
Okay,
Now
okay.
they have been muted. Yes.
Okay,
Okay,
okay. So you have to pre-oxygenate, isn't it?
Yes, sir. Pre-oxygenation.
So is there any problem in pre-oxygenation of these patients?
So in these patients, the pre-oxygenation time is increased, sir.
Very
Because
good.
of the time constant.
Time constant is prolonged.
It is
What is time
pro-
constant? What is it a product?
Product of compliance and resistance. Sir.
Yes. What about compliance in these patients?
Compliance is reduced, sir, and resistance is increased.
Emphysema, the compliance is
increased.
It's a big lung.
Compliance is increased and resistance.
Increased compliance, increased resistance.
Increased resistance.
Both are increased. So time constant for
Will
filling
increase.
disease or denitrogenation is increased. So naturally, these patients will take a longer time to oxygenate, maybe 5 to 8 minutes.
8 minutes.
So you should have an end target, isn't it? ETO to target. When you are
90%. 90%.
more than 90% ETO2 should be the target. Okay. Then that is one problem in pre-oxygenation of these patients that you should always think about. And another thing is they may desaturate during your laryngoscopy and intubation. How do you prevent it?
Sir, apneic oxygenation we can go for.
Now
Either with
it is not called as apneic oxygenation, it is called as para-oxygenation.
yes,
Pre-oxygenation and para-oxygenation.
para-oxygenation.
So how do you do this para-oxygenation?
So two ways, one with the nasopharyngeal airway
No.
and other with the buccal.
Nasopharyngeal airway, you can give
Buccal also.
nasal oxygen.
Nasal
Yes,
oxygen.
No desat. What is no desat?
Sir, high flow nasal oxygen.
No, it is not high flow. No desat is regular flow. No desat is nasal oxygenation during the attempt of securing an airway.
Yes, sir.
That is no desat.
Yes, sir.
Nasal oxygenation during attempt of securing.
Securing an air.
That is no desat. So you give 10 to 15 liters of oxygen through the nostrils continuously while you are doing. That is an apneic oxygenation only. It is producing.
Yes.
But it's called as para-oxygenation.
Para-oxygen.
Yes,
So
sir.
just to differentiate between pre-oxygenation and
Para-oxygen.
Para-oxygenation. Yes, sir.
okay, another thing you can try is thrive.
Yes, sir.
What is thrive? What is expansion of thrive? Transnasal, humidified, high flow,
Nasal oxygen.
rapid insufflation of oxygen
Yes, sir.
or rapid insufflation ventilatory exchange.
Yes, sir.
That is thrive, isn't it? Transnasal, humidified,
Humidified, rapid,
high flow,
High flow, rapid
Rapid
insufflation,
insufflation, ventilatory exchange. Because there is going to be exchange of carbon dioxide also. So the advantage of thrive in these patients is it also maintains a CPAP
Yes, sir.
and it prevents collapse of the airways. So that definitely, you know, the closing capacity, though in these patients, the functional residual capacity is very high. But closing capacity is higher than the functional capacity.
Yes.
That is why they rapidly desaturate. So thrive by making or by keeping some amount of CPAP, because every 10 liters of thrive, it maintains 1 centimeter of CPAP.
Yes, sir.
So that means if you are using about 50 liters of oxygen for thrive, at least 3 to 5 centimeters of CPAP will be there. So it prevents collapse of the airways when you are manipulating the airway, and that will prevent closing capacity to increase.
Yes, sir.
So these are the other two things which you should always remember when you are managing airway of these patients. So no desat, thrive, para-oxygenation is important. And pre-oxygenation, you pre-oxygenate them by elevating the head end.
Yes, sir.
And also CPAP of 5 centimeters.
5 centimeters.
Like in obese restrictive lung disease patients, here also you give CPAP so that you reduce the closing capacity. So that you improve the FRC, reduce the closing capacity, so denitrogenation will be better. Okay, so that is very important. Okay, now we have induced the patient with propofol. Now you have put an endotracheal tube. So how do you maintain this patient? Now is the maintenance.
Yes,
So
sir.
main goals of anesthesia will be to maximize the alveolar gas emptying, sir.
We'll use inhalation agents, sevoflurane to
So
maintain.
you have to reduce the dead space.
Space and to minimize
You have to have
hyper.
a better exchange of gases.
Allow adequate time for expiration,
Expiration.
sir. Lower respiratory rate and increase the
No, first of all, when I say how do you maintain, first of all, what are the gases you want to start off?
yes, sir.
Now, till now, you have started with only pre-oxygenation, 100% oxygen you are giving. Now, you cannot give 100% oxygen, isn't it? That will produce more atelectasis. Postoperative hypoxemia it can produce. So, how you are going to manage? Now, what gases you will be giving?
Oxygen and air, sir, along with the sevoflurane. Agent of choice, sevoflurane.
Yeah, you don't want to go for nitrous oxide. What is the reason for not going in for nitrous oxide?
Presence of any blebs, use of nitrous oxide might cause the bulle rupture and sudden pneumothorax.
Yeah, that is one thing. Second thing is, what is the effect of nitrous oxide on pulmonary?
Systolic pressure. Pressures will be high, increases.
So that is how, and laparoscopic surgery, as such, you will be avoiding nitrous oxide. So air, oxygen, ventilation, you can always do, isn't it? So what is the FiO2 you want to maintain?
More than 40%.
No, ideally around 0.4 is enough.
Yes, sir.
Isn't it? You need not have to go for a higher FiO2 because higher FiO2 can produce atelectasis.
Yes, sir.
That is always there. So even in the post-operative period, you have to be very careful in how much of oxygen supplementation you will be giving for these patients, because they can develop carbon dioxide retention, isn't it? What is the cause for carbon dioxide retention in these patients in the post-operative period? Tell me. Huh?
Basal atelectasis.
Based on?
No, sir. Basal atelectasis and hypoventilation, sir, due to opioids, sir.
No. In COPD patients, you should be very careful in oxygen supplementation, isn't it? What are the reasons?
So reactive oxygen species increase.
No. You're not catching my question.
The ventilated drive is...
See, one of the older theories is they'll be on a peripheral, hydrogen ion chemoreceptor stimulation, ventilation, like hypoxic drive. Hypoxic drive is through the carotid bodies, isn't it?
Yes, sir.
Central hydrogen ion chemoreceptors. The central hydrogen ion chemoreceptors are saturated because of continuous increase in carbon dioxide levels. So if you oxygenate them, they lose this hypoxic drive. So they may hypoventilate and then they can have hypercarbia.
Yes.
That's the older theory. What is the present theory? There are two present theories are there. One is the Haldane effect. Haldane effect is higher the reduced hemoglobin, more carbon dioxide it can carry. The opposite is true. If hemoglobin is oxygenated more, less carbon dioxide it can carry. So start giving oxygen, you are oxygenating the hemoglobin.
Yes, sir.
That means reduced hemoglobin is oxygenated hemoglobin is more. It cannot carry carbon dioxide from the blood to the alveoli. So carbon dioxide retention can occur. This is one of the latest theories that has been put forward why they develop hypercarbia. What is the second theory?
Bohr. Not
Bohr effect. Second theory is, suppression of the hypoxic drive. Because, oxygen, when you give more, it suppresses the hypoxic, not hypoxic drive, hypoxic vasoconstriction.
Yes, sir.
Inhibition of the hypoxic vasoconstriction of the lungs. Because there are so many areas where there is hypoxic vasoconstriction, and because of that, the blood flow to these areas is reduced.
Yes,
Suppose when you give oxygen, these areas, the vessels will dilate. So what happens is now the blood is diverted from the oxygenated, ventilated areas to these areas. So the shunt increases, more than the shunt, dead space increases. Because already these patients have got a VQ more than 1. Ventilation is more and perfusion is less in those areas. And from there, even if perfusion is diverted away, so they go for more dead space, more retention of carbon dioxide. Now you remember about the latest theories, isn't it? So you have to be careful how much is the FiO2 you want to keep intraoperatively and postoperatively.
Yes, sir.
Maintain this FiO2. Okay. So then again, the ventilation, how do you fix your ventilator?
So you go for a low tidal volume and a low respiratory rate, sir.
Low tidal volume.
Around 5 to 6 ml per body kg of body weight, and respiratory rate I will maintain it around 10 to 12, sir.
Okay.
And also the inspiratory and expiratory, prolong the expiratory ratio, sir, so that patient doesn't go for auto peeps.
Auto PEEP you have to prevent. That is one thing. And barotrauma, volutrauma, atelectauma, biotrauma.
Control ventilation is preferred, sir.
Yeah, that is why you go for low tidal volume strategies, and also to prevent auto PEEP, you will go for low respiratory rate and a prolonged expiratory time. So that, the patient can expire his expired gases from the lungs, so that auto PEEP is prevented. Do you want to keep some amount of PEEP, or you don't want to keep PEEP?
We want to keep PEEP, sir.
Yeah, minimum 5 centimeters physiological PEEP.
Yes.
Physiological PEEP is very important, so you should keep physiological PEEP of 5 centimeters. Okay, now that's how you maintain. And what is the dreaded complications intraoperative?
So bronchospasm, sir.
Intraoperative bronchospasm. So how do you recognize intraoperative bronchospasm?
So sudden increase.
There will be sudden increase in airway pressures, sir.
Okay.
And chest auscultation will be able to hear wheezing, sir.
Okay.
Wheezing, or if the bronchospasm is very severe, then the chest will be silent, sir.
Okay. What about the chest movements?
Chest move.
It will be reduced, sir.
Chest movements will be reduced.
Movements.
Bronchospasm. Okay. Then.
And capnography will show sharp fin appearance, sir.
Yeah, very good. So these are the ways you can recognize intraoperative bronchospasm. So if you suspect intraoperative bronchospasm, there are many other conditions which can mimic this, isn't it? Which can also increase the the airway pressures, which can also produce a sharp fin appearance also in the ETCO2. So what are the other causes which can also produce this kind of a thing?
Sir, any tubal obstruction, sir.
Okay, that is the more common than intraoperative bronchospasm.
And kinking of the tube, sir.
Yes, okay. How do you differentiate this?
Sir, visually we inspect from the machine to the patient end, sir. So,
but it can kink in intraorally also. Or it can get plugged by mucus plugs, because they are very common in these patients, COPD patients.
Endotracheal suctioning.
Yeah, you just pass a suction catheter beyond the endotracheal tube. If it can go through and through, it takes hardly about few seconds.
yes, sir.
You just disconnect, pass it. If it can pass through and through, there is no problem, isn't it? So you can reconnect. Now you'll have to think about other causes. What are the other causes?
Endobronchial intubation.
Yeah, endobronchial. That you can immediately know by just auscultating.
Yes.
Both things. Okay. What else?
Lighter plane of anesthesia, sir.
Yeah, okay. Then tension pneumothorax.
Tension.
It is a dreaded one. You will have to differentiate between endobronchial and tension pneumothorax.
Yes, sir.
That you can easily make out by percussion.
Yes, sir.
Isn't it? Hyperresonant note on the side where you are not able to hear the sounds, respiratory sounds.
Yes.
Not be hearing because lung collapse would have been there, but there will be hyperresonant note is there. That's how you differentiate between endobronchial and pneumothorax, because management entirely differs all these things. If it is endobronchial, you just pull out the tube.
Yes, sir.
If it is tension pneumothorax, what you have to do?
We have to put a needle, sir, and the second.
And then you have to go for a chest drain.
ICD.
Yeah, ICD you may have to go for. So that is another important thing about. Then what other things?
Pulmonary embolism must be.
Pulmonary thromboembolism, but
Thromboembolism.
not produce typically these things. But aspiration of stomach content,
Yes, sir.
isn't it? Suppose you have taken a full stomach patient. If he has aspirated, you will not be able to ventilate. The airway pressures will go up like anything. You'll
Yes,
desaturate rapidly, isn't it?
Yes.
So, but that you can make out when you are doing a laryngoscopy itself. You can see the food particles there.
Yes.
And then one more. Pulmonary edema.
Yes.
Again, in pulmonary edema, airway pressures will be very high because the lung is filled with water fluid.
Yes.
So these are the things which you have to differentiate. So once you have, ruled out all these things, now you know that it is a intraoperative bronchospasm. Oh, how do you manage?
First, I'll ask the surgeon to pause the surgery, sir.
Stop manipulation.
Then and give the patient with 100% oxygen, sir.
Okay.
Deepen the pain.
And then deepen the plane of anesthesia with incremental dose of propofol or ketamine also, sir. Because since
How about inhalation anesthetic agents?
Yes, sir.
yes, sir.
We have
No,
to
it's
give-
not ideal because they may not reach the alveoli
Yes, sir.
because there is bronchospasm.
Yeah.
Yes.
So inhalation route they may not reach, isn't it? Much.
Yes.
So, but you can definitely increase the inhalational anesthetic output concentration of the vaporizer also. In the meantime, you give propofol and fentanyl because pain also may be the cause.
Yes, sir. Lighter plane of
An additional dose of fentanyl. Okay, then.
And then endotracheally, you can ask the patients you can give the bronchodilatory,
short-acting.
bronchodilatory.
Yeah, whatever this thing is there, beta 2 agonist,
And
you
then
can always give the puff by using a adapter is there. A separate
Yes.
adapter is will be available that you have to keep ready.
Yes.
And to that adapter using a multi dose inhalational PI, you can give how many puffs you should give?
usually three puffs,
No. You have to give more than 10 puffs
10 puffs.
because much of the drug will remain in the endotracheal tube itself. That is called as a reining in of the drug. It gets reined in inside the tube itself. It may not reach the distal airways. So that is why higher dose, 8 to 10 puffs, ideally around 10 puffs you may have to give. So you are given that also, but still there is not much of a
IV steroids, IV intravenous hydrocortisone.
Yeah, but steroids will take a long time. I told you, onset of action is more than 1 hour. Peak effect.
Adrenaline.
Yeah, you can give IV adrenaline.
IV adrenaline.
How much IV adrenaline?
100 mic.
100 mgs.
It will produce immediately in a hypoxic patient atrial fibrillation or ventricular fibrillation. Don't go beyond 10 micrograms.
10 mics.
10 mics increments you can give, or you can go for 0.5 to 2 micrograms per minute infusion you can start.
Yes, sir.
Okay. What else?
Twice the dose of atropine.
Pardon?
Twice the dose of atropine.
Atropine will not help. Because the atropine produces large airway dilatation. These are smaller airway narrowing has occurred. Atropine may not help.
Magnesium
sulfate.
Yeah, magnesium sulfate. Before that, lidocaine you can give.
Yes.
Additional doses of lidocaine because lidocaine produces bronchodilation and it also increases the depth of anesthesia. Two advantages are there. So lidocaine you can definitely use. Then ketamine already you have said 0.5 milligram per kg body weight ketamine. 0.5 milligram per kg per hour infusion also you can start.
Yes.
Then magnesium sulfate is another important thing you can always give. How much magnesium sulfate?
So 1 to 1.5 milligram per kg.
Usually 1 to 2 grams, not milligrams.
Sorry.
2 grams IV magnesium sulfate you can give. So these are the ways to manage. Suppose you don't want to give 100% oxygen, anything else which can increase the flow, you can use, suppose if it is available for you. Heliax. Helium oxygen mixture.
Helium.
Yes.
Heliax.
Yes.
Why heliax can help in these patients with bronchoconstriction?
Sir.
In
So
these,
narrow pressure, the
Healy.
see, one thing you should realize, the density of helium is very less
Yes, sir.
compared to oxygen or air, what you're using. So here now, what has happened is because of the narrowing, there is turbulent flow has occurred. Turbulent flow is inversely proportional to density, turbulent.
Yes.
If you reduce the density, flow can increase.
Yes.
So though there is bronchoconstriction, the resistance offered by these airways for the flow of gases will be much less. That is why helium oxygen mixture is one of the drugs that is commonly used for breathing in patients with bronchospasm or any acute bronchial asthma.
Yes.
Or here also you can use. But what is the disadvantage of Heliox?
Helium, so air embolus.
No. What is the maximum amount of oxygen that is present in Heliox?
50%, 50%.
30%.
30%.
So you require a higher FiO2, so you'll not be able to give, because if you go for higher FiO2 with less helium, then the benefit is not there. It is not going to reduce the density. Density increases if you are giving higher FiO2. So Heliox is also one of the gases you can use. Okay, this is how you should manage. This is one of the common questions for you that is asked when you are managing GA for these patients. So another one is the fluid management. So depending on what is the kind of surgery, you go for major surgery, you can go for goal-directed fluid therapy. Yeah, otherwise, you can definitely go for slightly more than the restrictive fluid, because hydration is very important in these patients, so that the viscosity of the
Secretions
to be decreased. So that is why that is important. Okay, now how do you extubate these patients?
preferably in a deep plane of anesthesia.
If there are no
contraindications.
Yeah, but deep plane of anesthesia can produce obstructed airway.
We can try the
Go for Bailey's maneuver.
Yes.
Yeah, you go for Bailey's maneuver. Last time when we discussed mitral stenosis, we had discussed about Bailey's maneuver. One very important thing you can always use in these patients also, so that the stimulation of the tube are coming out, because now the patients are coming out lighter planes. So there is always a chance of bronchospasm. So you have taken out the tube from the endotracheal region and you have placed a supraglottic airway device, which does not produce so much of stimulation of the air. So that's why, Bailey's maneuver you can definitely try. And post-op analgesia is very, very important in these patients. Pain is the one which can produce decreased effort for
coughing,
breathing and coughing. So that you have to keep in your mind, and good amount of pain relief. And during pain relief, what about non-steroidal anti-inflammatory drugs?
So we should avoid NSAIDs.
Yeah, because they directly can produce
trigger bronchospasm.
Yeah, bronchoconstriction they can produce. So that is another thing which you should always keep in mind, because routinely we'll be using NSAIDs, isn't it? So better not to use at all. So here local infiltration and also intraperitoneal infiltration of the local anesthetics can use. That may be enough, isn't it? And again, postoperative hypoxemia is very, very common in these patients. So you have to, again, postoperative pulmonary complications are very important. So what are the methods to prevent postoperative pulmonary complications in these patients?
So, CPAP or initiation of CPAP or BiPAP.
Okay, one thing is lung expansion maneuvers. You can continue with incentive spirometry.
Deep breathing, physiotherapy.
Yeah, and also use CPAP method. Early mobilization.
Early mobilization.
That is the most important thing. Prevention of DVT.
Yes.
That is another thing. And, adequate pain control.
Yes.
So these are the ones, and good hydration in the postoperative period.
Yes.
So these are the ones which can be used for prevention of postoperative pulmonary complications. Okay, so these are the things which you are usually asked. Actually, we could have discussed in detail about postoperative hypoxemia. Just remember about causes for postoperative hypoxemia. What are the causes for postoperative hypoxemia?
Just like basal atelectasis.
From the beginning is one thing is diffusion hypoxia. If you are using nitrous oxide, isn't it? That is the first thing that can occur within half an hour.
Yes.
Then alveolar hypoventilation because of the various drugs what we are using, and continued action of these drugs can, residual effects of these drugs can produce. And the other thing is, the diaphragm will move up in the post-op period once you have given muscle relaxants or inhalation anesthetic agents. So that is the one which produces decrease in FRC, increase in closing capacity. So that is the one which can produce. And again, the postoperative period hypotension. Again, postoperative hypotension can lead to hypoxia because stagnant hypoxia,
Yes.
isn't it?
Yes,
So,
yes.
and tight abdominal binders, if there is an open surgery, so that also can produce problems. So these are some of the important causes for postoperative hypoxemia, which you have to keep it in mind and prevent these things. Okay.
Yes.
So that concludes our discussion on COPD and anesthesia. So if you have any doubts regarding this, next class we can briefly first 5 or 10 minutes. If you just ask your friends and you also may have certain doubts, we can just discuss and then next we will go for the next case. Mukhtar, what is the next case discussion?
CKD, sir.
CKD.
CKD. Okay, chronic kidney disease. So suddenly Ramnathan said, oh no, we'll not mention CKD, we should expand it. So good that both of you have answered very well, you have studied well. And if this is the kind of preparation even month before the exam, so during a exam, so you must be, you should be doing well. So all the best.